Carolyn Hadley is one. She grew up in the Adams Morgan area of Washington, D.C. She went to the world-renowned, actually a superb school, the Friends Academy, in between the Clinton child and the two Obama children. It is probably the best education in Washington, D.C. And then she went off to Duke University, where she earned a bachelor's degree in both French and biology. From there, she went on to Baylor College of Medicine, not before she did a sub-I with us in the year of Dr. Meyer and Bass. And she did a spectacular job, but chose the way the scramble worked. She ended up at Baylor with Dan Yosher, and she did a fabulous job there, according to Dan. And she came here to work with doctors Shaker, Ferreira, Emerson, and Ruzovic on the skull-based team and vascular team, and she does vascular as well as skull-based. And she has won all sorts of awards. When she was at Baylor, she won the Presidential Scholarship and the DeBakey Scholarship, and all kinds of academic awards for the papers she's produced. And speaking of papers that she's produced, she's contributed to over 34 peer-reviewed papers. She's been a fabulous fellow. Every single one of her residents, who really, that's a high bar when our residents say, oh, they love Carolyn. She's wonderful to work with. She teaches us a great deal. So Carolyn, I don't want to take any more of your time. You're going to talk about a fascinating subject. So thank you so much for being such an outstanding fellow here and part of our department. Everybody here adores you. Okay, Carolyn, take it away.
Thank you very much for that extremely generous introduction. I'm going to talk a little bit this morning about meningiomas and sort of the changing landscape of classification of meningiomas as we move into the era of molecular medicine. So I'm going to go over a little bit of a historical perspective and early classification of meningiomas, and talk a little bit about where next generation sequencing has taken us with classification. And then go over something we've been developing at Baylor, which is a multi-component classification system for meningiomas. And then at the very end, I'm going to pivot a little bit and talk a little bit about superior sagittal sinus involvement in meningiomas. So I'm a little bit of a history nerd. So just in sort of a little bit of background in the history of meningiomas, the first academic description of meningiomas was in this monograph in 1614 by Felix Platter. They actually have found meningiomas in Neanderthal skulls. So this is clearly something that has plagued humanity well before that. The first reported resection was performed in 1646 by Marcus Aurelius Severinus, and he referred to it as a fungus tumor of the dura mater. For some time thereafter, treatment of meningiomas really consisted largely of exposing the tumor and putting some type of caustic substance on it, such as potash, which you could imagine had predictably catastrophic results. In 1774, Antoine Louis, a French neurosurgeon, published a treatise advocating for resection rather than this sort of more classic approach. And then in 1835, an Italian surgeon called Zanobi Pecchioli performed the first successful resection. Harvey Cushing, sort of probably the most famous person for writing about meningiomas, in 1922, published his series and actually coined the term meningioma. He reported not only a series of successful resections defined as, to mostly tumor removal and a patient who survived the operation, but he also observed recurrence in these tumors which were previously really thought to be benign. As early as 1955, Folke Henschen had reported the absence of a reliable relationship between histology and tumor behavior, meaning many tumors that were removed successfully and appeared to have benign histology were noted to recur. This phenomenon has kind of been observed throughout the 1900s in writing about meningiomas. Most famously, Donald Simpson's paper, the Simpson criteria for characterizing extent of resection. He and others at the time reported that total resection was associated with decreased recurrence. However, even with total resection, there was a 9% recurrence rate, which didn't really make sense to them for a benign pathology. So going forward after the area of resection alone, the recurrences started to be managed with radiation. First, external beam radiation, typically a dose of 50 to 55 gray in 1.8 to 2 gray fractions. Now that's sort of a more modern dosing scheme. Obviously, during the development of these paradigms, a lot of different dosages were used. Reports were variable, but in general, the theme is that with this management strategy, regression is unlikely. It's really a growth arrest. But progression-free survival at 10 years can be quite good, up to 100% in some series, but hovers more around 80%. Stereotactic radiosurgery can also be used to control residual or recurrent meningioma growth. Typical dose for this is 12 to 16 gray, depending on the location of the tumor. And this can have very good local control rates, 75 to 100% at 10 years. However, as we all know, there's a significant risk associated with radiation necrosis, particularly in patients who have long survival of, as well as damage to adjacent structures. So this brings us to 2000, where the WHO grading classification for meningiomas assigned grades really based entirely on histopathology. And they characterized several different histopathologic subtypes, all of which were assigned grades 1, 2, or 3. Problem with this grading scale really is there's a high degree of inter-observer variation. So the criteria to classify a meningioma as one thing or another was not always reproducible across pathologists, meaning patients who got treatment at one center may be characterized differently than they would be at other centers. Additionally, there was not a great correlation between the grade and the outcomes for all patients. Most WHO grade 1 patients had a very benign course. However, there were patients who had graded WHO grade 1 lesions who had very aggressive recurrences, which means that grading scale is not terribly useful for prognostication. In 2007, the WHO grading classification was modified to incorporate some features that were hopefully a little bit less subjective to better characterize meningiomas. This added brain invasion, cellular atypia, presence of anaplesia, and a high degree of mitotic activity, all of which were capable on their own of elevating the grading scheme from 1 to 2 or 2 to 3. Even this updated classification is not always helpful, as grading, again, does not predict recurrence rate reliably. Most patients follow the line of grade 1 is more benign, grade 2 slightly more aggressive, and grade 3 quite aggressive. But there are, of course, patients who have grade 1 tumors who have very aggressive recurrences. This classification is also confounded by intratumor heterogeneity and sampling error. Brain invasion is hard to evaluate if the sample doesn't necessarily include invaded brain. So it is not as ideal of a grading scheme as it could be. And this really moves us into establishing sort of a genetic-based landscape. More recently, this has become kind of a theme in terms of all neoplasms and cancers, is defining a genetic or molecular signature for these tumors to identify potential targets for therapeutic intervention. The initial genetic landscape for meningiomas is really NF2. So the early characterization of meningiomas comes largely from the neurofibromatosis literature and the identification of chromosome 22 loss encompassing the NF2 gene. Just as a reminder, NF2 encodes a protein called myelin, which is a cytoskeleton scaffolding protein that contributes to cell proliferation and survival. It's obviously seen in all loss of myelin is seen in all neurofibromatosis patients. However, loss of heterozygosity is also seen in 40 to 70% of sporadic meningiomas. And in those patients who have a single chromosome deletion, there are additional mutations in the other myelin gene in 60% of tumors, meaning that there is a complete loss of function. For a while, that was really the main thought behind meningiomas. There were some other early genetic alterations that were identified based on sort of things that had been identified to be disrupted in other types of pathologies, BCR, DAL1, as well as chromosome losses, which were identified to be associated with more aggressive phenotypes in meningiomas. Obviously, genetic instability conferring a more aggressive phenotype. So this brings us to the sort of era of next generation sequencing, which really has changed the face of evaluation and treatment of many different types of tumors, not just meningiomas, of course. So the first thing I want to talk about is somatic mutation-based grouping. From this is not advancing. There we go. The next generation sequencing kind of became very popular in meningioma research in sort of the 2010-2020 era. In 2013, a group at Yale published a large whole exome sequencing analysis of 300 tumors, and they identified new subgroups of meningiomas based on the known and well-characterized NF2 mutations, but identified novel mutations groups, TRAF7, SMO, KLF4, and AKT1. These were all mutually exclusive with NF2 mutations, suggesting an explanation for the non-NF2 mutated sporadic meningiomas. Just as a little bit of a review, TRAF7, the function of these proteins are really all cell division, and not surprisingly, TRAF7 is a pro-apoptotic ubiquitin ligase, SMO is a repressor of hedgehog signaling, KLF4 drives differentiation, and AKT1 inhibits a apoptosis pathway, PI3K AKT. They also reported that chromosomal instability was associated with higher grade tumors, and that non-NF mutated tumors have a higher rate of genomic stability, meaning we would expect those to be less aggressive in their behavior. Additionally, this group defined a separate sort of gene expression pattern between NF2 and non-NF2 mutated meningiomas, which is consistent with their identification of these unique somatic mutations. And then lastly, they examined whether these specific mutations were associated with different locations. That's a sort of an important thing to identify because we know the extent of resection is highly variable based on involvement of critical structures. And so if we're going to be if the goal of identifying these genetic backgrounds is treatment, we need to kind of know what things are likely to recur and what things are likely to be subtotally resected so we can target therapeutic interventions. Follow-up to this study from the same group identified an additional subset of tumors who had an inactivated mutation in this RNA polymerase, which sort of cemented these somatic mutation-based characterizations for meningiomas. An additional study actually out of the same group, slightly different set of authors, identified an increased incidence of NF2 mutation in higher grade meningiomas. This is in keeping with what the original paper found about the changes in genomic stability associated with NF2 mutations. The NF2 mutation, as we mentioned before, is seen in 40 to 60% of sporadic meningiomas, but was actually in 75% of histologically atypical meningiomas. And with those tumors, that was associated increased changes in copy number variation. They also identified SMARCB1 mutations, which were associated with higher histologic grade and co-occur with NF2 mutations. And then lastly, they found that TRAF7 and KLF mutations and RNA polymerase hedgehog pathway mutations were not observed in any atypical tumors. And this is really important because this allows us to kind of determine that there is really a genetic difference in tumors that are likely to be aggressive with tumors that are likely to follow a more indolent course. Which is helpful in counseling patients and ultimately, hopefully, will be helpful in development of targets for therapeutics. The Heidelberg group also identified at the same time a TERT promoter mutation. Telomerase reverse transcriptase, as we all remember, drives elongation of telomeres, facilitating immortality in cancer cells. This is pretty well characterized in cancer. But this group in Germany found that a TERT promoter mutation was associated with recurrences across all grades and progression to higher grade at recurrence in grade 1 and grade 2 tumors. And then lastly, the Sievers group looked at cyclin-dependent kinase inhibitors. Again, something that is talked about a lot in malignancies. And they found also that homozygous deletion was present in almost 5% of a large series. And these patients had a significant increase in their time to progression of 8 months compared to 101 months in the non-mutated cohort. So this prompted an update to the 2021 WHO grading criteria. This incorporated 2 of these somatic mutations in grading of meningiomas, presence of TERT promoter mutation and homozygous loss of CDKN2A and B is now allow a lesion to meet criteria for grade 3 designation. The groupings, the somatic mutation groupings were not incorporated into any type of grading scale because they don't necessarily correlate well with histologic grading. Additionally, in addition to somatic-based mutations, there's also some identification of cell signaling pathways that were noted to be disrupted in meningiomas. And the 2 main ones here are hedgehog signaling and Wnt, both of which have been discussed in medulloblastoma literature previously. Just as a reminder, hedgehog pathways are cell survival pathways, and the activators SMO, GL1, and FOXM1 overexpression are seen in multiple types of meningiomas, while SSP1 and IGF2 overexpression is seen in more aggressive phenotypes. Additionally, some negative Wnt regulators, CDH1 and BCR, are often downregulated in meningiomas, and SFRP1 downregulation is common, particularly in recurrent meningiomas. And moving into sort of more recently, the transcriptome profiling has become a sort of the next step of evaluation of next generation sequencing. So the Harmansi group at Yale did an unsupervised clustering analysis of their large meningioma patients. This is the same patient population from the somatic tumor groups. And they found that the mRNA expression profiles really didn't cluster well to the WHO groups. They did find that there were 3 distinct groups, but the clustering was better explained by NF2 mutation presence or absence, and then within NF2 mutations, the presence of high copy number variation versus low copy number variation, meaning a high degree of genomic instability versus a low degree of genomic instability. They identified 483 genes that were differentially expressed between benign and atypical tumors within these subsets. And I want to highlight 2 of these genes because they're going to become important later. And one is FOXM1, which is an important component and also target of the DREAM complex, and EZH2, which is an important component of the PRC2. And then sort of lastly, for the trifecta of advanced sequencing, is looking at DNA methylation and its contribution to meningiomagenesis, and then also clinical course of meningiomas. So this same group out of Germany described meningioma subgroups based on DNA methylation profiles. So they had a cohort of 496 patients, and they demonstrated first that methylation patterns cluster meningiomas separately from other extraaxial and skull-based tumors of mesodermal origin. And then they next also did unsupervised clustering based on methylation signatures that assigned 2 distinct groups of meningiomas with a total of 4 subgroups distributed between the 2. They named these groups according to their behavior. So there are 3 benign, 2 intermediate, and 1 malignant group. And there is some correlation between these methylation groups and histologic WHO grading. Grade 1 primarily maps to the benign group. Grade 3 primarily maps to the malignant group, but grade 2 is kind of scattered across all groups. And this makes sense when we see the clinical heterogeneity within the WHO grading. They did note some clustering of the canonical meningioma mutations within these groups. You can see in this figure here, NF2 is kind of distributed throughout all of them, but the TRAF7, AKT, KLF4 mutations really cluster to this, what they call BEN2, whereas NF2 is kind of more distributed throughout. These groups also correlate somewhat with previously identified groups based on chromosome losses and histologic grouping. But most importantly, they correlate very well with worse progression-free survival. They correlate better than WHO grading. And you can see in this figure on the bottom here that really within each group, the progression-free survival just gets worse and worse. I also want to point out that in the malignant group, it's the gender distribution is more than 50% male. Just as a reminder, meningiomas have a 2-to-1 female predominance, but this increased incidence of more malignant meningiomas in men certainly matches up what we see clinically, where male patients are at higher risk for a more aggressive clinical course. So that's a lot of stuff that I just kind of went through very quickly. But in summary, there have been several methods that have been used to establish molecularly similar groups, including somatic mutations, transcriptome profiles, and DNA methylation signatures. The WHO meningioma grading has been updated now to include molecular criteria for grade 3 designation. And so our ability to identify grade 3 lesions is much better at this point. However, we still see aggressive behaviors from lower graded lesions, which makes this grading scale not always the best prognostic factor in counseling our patients. So I'm going to move on to what we've sort of been doing at Baylor and working on establishing a new classification system that sort of does two things. That one allows us to better predict and better counsel patients of what their clinical course is likely to be. And two, hopefully allows for the identification of some targets for therapies when patients have recurrence after total resection or when total resection is not possible. So this is the sort of first stab at transcriptome-based classification. So our group at Baylor performed a principal component analysis on transcriptomes from a 160 sample series. And similarly found no clustering based on WHO grading, which recapitulates findings from several other groups. We then also used two methods of unsupervised clustering to identify to ask really whether there were genetic similarities between tumors in this series. And this identified a set of 1,500 genes, which were noted to be most variable across the three samples, across the three subgroups, which were identified. This was then validated by principal component analysis. And interestingly, there was a distribution of meningioma types within these groups. So group A, as defined by our transcriptome analysis, was all WHO grade 1 tumors. Group B had a mix of 1 and 2, and then group C was pretty close to half and half 1 and 2. I should mention these are all WHO grade 1 and grade 2 tumors included in this analysis. We only used tumors that had no prior treatment, and the incidence of upfront WHO grade 3 meningiomas is quite low. So this sort of gave us these three genetically similar appearing groups. So then obviously the next question is, what does this mean? What does this do? Do these groups have any type of behavioral significance? So we then did a pairwise comparison of gene expression within groups to identify differentially expressed genes and create a sort of heat map profile. This identified about 3,400 differentially expressed genes, which were used to generate a random forest classifier, which was then validated on a separate cohort, as well as a publicly available data set of meningioma transcriptome. And this was really quite reproducible. It gave us these same 3 groups, which we've arbitrarily called type A, B, and C. So then the question becomes now, these have the same transcriptome signature. What does this mean in terms of their behavior? So the next thing we looked at was the mitoses by using MIB1 index between and comparing this between the different groups. We did see a significant increase in the MIB1 index, excuse me, in both the discovery and the validation cohorts, based on group designation. When you stratify these within groups by tumor grade, this trend goes away. The significance goes away, but the trend is still that regardless of the WHO grading, as you go up the groups, the mitotic index becomes higher. We also looked at whether this is associated with a specific location. The location assignment is not quite as robust as that reported by the Yale group. There was some clustering of group A for the anterior skull base, and group C for the occipital area, which kind of matches up with some of the Yale somatic mutation groups, which I'll talk about a little bit later. And then similarly to other studies, we did find that the group C group, the more aggressive group, were 56% male, which again falls in line with our observed worst clinical course for male patients. And then the last sort of part of this is, does this correlate with progression-free survival? So groups A and B had similarly low rates of recurrence. However, group C had a significant increase in progression. And this was true both for patients who had progression of residual disease and also patients who had a gross total resection. When we broke this down by WHO grouping, there continued to be a significant increase in recurrence and progression in group C tumors. When just WHO grade 1 graded tumors are taken into consideration, the recurrence rate is low and consistent with literature reports in group A and B, 8.6 and 4.2% respectively, but is 33% in group C, which is consistent with the MIB1 index suggestion that these are more mitotically active and therefore likely to be more aggressive. We next look at genomic instability across these groups, and not surprisingly, sort of recapitulated what other groups have found in looking at aggression associated with genomic instability. So group A had no significant gains or losses. Group B tended to have loss of chromosome 22q, observed in 84%. And then group C had the highest level of genomic instability and typically had loss of both chromosome 22q and 1p. 20% of these tumors also showed additional losses at various loci. A copy, again, not reinventing the wheel here, but copy number loss in our series also predicted recurrence, and loss of both 22p and 1q predicted recurrence after gross total resection with 100% sensitivity and 76% specificity. And then we looked at where these somatic mutations fall within our transcriptome-based groups. So not surprisingly, based on the location analysis, all TRAF7 mutated tumors tended to cluster to group A. These are the anterior midline skull base. The group A also had the highest proportion of KLF4 and AKT mutated tumors, and notably had no NF2 mutations, as well as no chromosomal gains or losses. Group B had NF2 mutations and was the predominant group for the NF2 mutation with associated SMARCB1 mutations. And then group C had NF2 mutations as well as chromosome loss at both 22q and 1p, as well as random chromosomal gains and losses. Of note, TERT-promoted mutations did not differ between the groups. So in our patients, only 108 had sequencing that included the TERT promoter mutation, or scratch that, included the TERT promoter. Of these, there were 8 who had mutations, and they were distributed across groups. The exclusion of grade 3 tumors is probably does not help this, because that is really thought to be a marker for grade 3 tumors. We obviously did not include them because we only included primary tumors in this analysis. And then lastly, we looked at pathway changes using gene set enrichment analysis, and this did show some defining pathways. Group A really showed no change in a single common pathway, but Group B showed a loss of PRC2 methyltransferase, and Group C showed a loss of DREAM complex activity. This is sort of the first analysis of these pathways in the role of meningiomas. So for everybody who doesn't remember, such as myself, PRC2 complex is a represses transcription by mediating H3K27 dietrimethylation. It mediates transcription of Hox transcription factors. This gene is a complex made up of several proteins, EED, SUS12, and EZH1 or 2. All of these components are expressed in all of these tumors. However, in type B tumors, immune precipitation of EZH1 does not pull down EED or SUS12, which suggests that this complex in these tumors does not form. And so this transcription repression is not happening. We confirmed that this was a important sort of step in meningiomagenesis in these patients by generating an inactivated form of PRC2 and transfecting it into 29-3 T cells, as well as an immortalized arachnoid cell line. And this actually reliably produced upregulation in 15 sort of signature genes found to be upregulated in Group B meningiomas. And all of those upregulations were statistically significant. So that really suggests that there may be sort of a unique pathway driving meningiomagenesis in that subset of tumors that produces a more indolent, less aggressive course. The Group Cs all show loss of DREAM complex activity. So the DREAM complex is a repressor of cell cycle genes. As you sort of hearkening back to the Harmansi paper, FOXM1 and MIBL2 expression are increased in the aggressive tumors in their group, and as well as in ours. But additionally, immunoprecipitation confirms that the inactive form of this complex is present in Group C, while the active repressor form is present in Groups A and B. This is just a cartoon that shows that this is a multi-component repressor complex that requires interactions with RBL2, E2F4, and DP1 in order to have a repressor effect, whereas associations with FOXM1 and MIBL2 lead to cell cycle progression. So the DREAM complex forms appropriately in both Groups A and B, but does not form appropriately in Group C, leading to cell survival. Similarly, in this group, we transfected two inactive subunits of the DREAM complex, and this produced reliably upregulation of 14 genes that were part of a gene signature for this Group C meningioma, and all of this was statistically significant as well. This is just sort of a cartoon to sort of see where this all fits in with NF2. So NF2 actually is part of what mediates phosphorylation of this MOVE-B complex, which allows DREAM complex formation. So it makes sense that loss of NF2 has an effect on DREAM complex, and the loss of NF2 results in loss of the repressor function of the DREAM complex. The thing that's interesting about this is that, as you may recall, our Group B meningiomas often also had an NF2 mutation, which suggests that something in their biology is rescuing them from this effect of NF2 loss. And then lastly, we looked specifically at progressive and recurrent tumors. and whether their profile of their transcriptomic profile changed with regression or progression. And we found actually that their profile stayed the same, even as they progressed from grade 2 to grade 3, or grade 1 to grade 2 lesions, which suggests that this group identity is kind of a defining component of tumorigenesis, and then as there may be additional degeneration from there. So in sort of summary of where we are right now, our transcriptome-based clustering identified 3 distinct groups of meningiomas, groups A, B, and C, and based on both somatic mutations and chromosome loss. And they contain some heterogeneity of WHO grades, which is consistent with previously observed phenotypic differences. Group C in our series is associated with more aggressive phenotypes. And then lastly, recurrent tumors may be more aggressive histologically and clinically, but they retain their transcriptome profile with recurrence. So the next step then is to look and see if this is recapitulated in other types of classification system. So this brings us to our methylation analysis. And really the question we had is methylation a reasonable signature for behavior in meningiomas, and do these methylation groups recapitulate the transcriptomic groups? So 110 primary meningiomas of the series that had received no prior treatment were evaluated using, again, 2 separate methods of unsupervised clustering. And they both returned the same 3 groups, which we designated methylation 1, 2, and 3. Methylation group 1 was balanced methylation. Methylation group 2 was globally hypomethylated, and methylation group 3 was globally hypermethylated in terms of promoter sites. We then identified a set of differentially methylated probes that were sort of the signature character for each of these 3 groups. We used this on 2 publicly available methylation cohorts to see if these signatures recapitulated these 3 groups. And this did appear to be reliable and found the same 3 clusters of methylation profiles. We then worked to develop a consensus classification comparing methylation-based groups and transcriptome-based groups. And interestingly, there was actually a fair amount of variation. So I want to draw your attention to sort of the first half of this colored figure here. And you can see at the bottom, there's a large sort of chunk of methylation of tumors that the methylation profile identifies as group 1 or group A, that are then transcriptomically felt to be group C, but then most of them, if you move on to other classification systems, go back to this A or 1 group. So in order to kind of try and tease out which one of these was going to be more accurate, we added in 2 other groupings, one based on cytogenetics, so no chromosome loss compared to just 22q loss compared to 1p and 22q loss. And then also these Harmansi classification of NF2 intact and then NF2 mutated with low and high chromosomal instability. This model taken together classified tumors into the same group in 91% of our cases. However, 9% of these were not well classified. And if you look sort of at this chart, you can see that the ones that are not as well classified really are in part these tumors that appear to be group 1 in the methylation group, but group C in the transcription group. And that suggests that there may be some similarities in the overall, in sort of what is the meningioma genesis event, but that chromosomal instability may be confounding that and making it a little bit harder to evaluate as they progress. So this consensus or combined classification also clustered somewhat with these known driver mutations. So again, TRAP7, KLF4, AKT1 all tended to cluster into what we will call MENG-A, which is the consensus classification group A. NF2 mutations were seen in both B and C. And then this clusters very well with what we know about chromosome loss. So chromosome loss of 22q only in group B, and loss of 22q and 1p in group C. Consistent with what we've observed previously, the male patients were more common in group C. But the other thing that I sort of wanted to highlight here is that while there certainly are more WHO grade 2 tumors in this C group than in the A or B group, 44% of Men-C tumors were actually grade 1 and exhibited an aggressive phenotype. And then the last part of this is, does this classification predict clinical outcome? Does this predict clinical correlation? So in all classification types, as well as the consensus classification, group C tumors had a significantly higher rate of chromosome loss and recurrence, as well as increased mitotic index. Meng-C tumors exhibited recurrence in 44% compared to 2.6% in group A and 4.8% in group B. So this is really robust. Now, the obvious question here is, have we just recapitulated the NF2 mutated versus NF2 low copy number variation, high copy number variation groups? And, the short answer to that question is yes. But I think the more nuanced answer to that is this gives us a little bit of information about what those changes are doing, and hopefully allows us to not only correlate that with patient outcome, but also identify targets, pathway targets that may be amenable to therapeutic intervention in the future. So in summary, transcriptome-based groupings may be limited in evaluation of more aggressive meningiomas due to the high degree of genomic instability and chromosome loss seen in these groups. Methylation analysis does reveal 3 different profiles with a high degree of similarity with groups based on chromosome loss, transcriptome profile, and NF2 status, with and without a high degree of genomic instability. And in the era in which we are now, where we have access to all of this advanced sequencing and molecular genetics, and integrated classification system may be better at providing prognostic information for patients, and also in guiding their treatments in the future. I want to express my thanks to the following people who are not here and won't see this, but were very important in doing all of this work. And then these are just some references here. I've got about 15 minutes. I have a little bit more stuff on superior sagittal sinus meningioma involvement, but I guess I can pause here, and if anybody has any questions.
Why don't we pause here, because that, by the way, your talk was superb, and may need some digestion. There are a lot of genetic details, just fabulous, and really did it in a nice order, I might add. Got a lot of compliments through text. Questions. Let's start off with some questions and comments. Manny, you do the genomics and proteomics work. Any thoughts? Anything to add here?
Well, this is terrific work. Great talk, Caroline, and you and Akshal really put it together with the transcriptomics. Very nice work. I think there's no question, whatever molecular technique is used, we see this heterogeneity, right? There's not just these 3 buckets. And as neurosurgeons, we see probably about 20 different buckets, right? And that's sort of what you're showing now when you integrate all of the molecular techniques. But there's been zero advancement, right? Our tools are still surgery and radiation. So when is the targeted therapy going to come? When are we going to see that panacea? AKT inhibitors don't work. Smoothing inhibitors don't work, and on and on and on. So what are your thoughts there?
So I think that's obviously, that's the interesting and sort of the $1 million question. I think the interesting thing to me about the sort of PRC dream complex mediation thing that we have identified with NF2 is that really the heterogeneity problem seems to be that tumors get rescued. So there's changes in different pathways that all lead to meningiomagenesis, but then you have secondary changes that rescue some, but cause different pathway problems. So I think the reason why this is such a difficult disease to treat with targeted pathway inhibitors is that there are multiple pathways at work within all of these groups. And I think you said it exactly right. There aren't just these three buckets. We recapitulate all of these things, but depending on the classification system you use, you can put different things in different buckets. And the degree of heterogeneity, I think, clearly means that you can alter one pathway, but rescue it with another in the same tumor subtype. And really, the answer, I think, is going to be in the age of sort of personalized and precision medicine, figuring out exactly what pathway is mediated in each person, and figuring out how you can sort of eliminate that rescue effect.
Great, thank you.
Thanks. Sheikh, you want to add in anything?
Yeah, I think it's truly outstanding work, Caroline. You've summarized a lot of information within a short time. And I kind of, let's say, in some ways disheartened by all of this information. And I echo what Manny has said, that still, it looks like surgery is the mainstay, followed by radiation therapy. And the more I treat meningiomas, I'm actually the anti-Almefti guy. I'm sort of looking at multimodal treatment, and Almefti always harps on total resection as the mainstay of treatment, but I'm actually getting closer to Almefti because the number of recurrences that I have seen in my own patients is very, very small. Even the radiation oncologists talked to me about this, that they found that even in grade 2 tumors, WHO grade 2 tumors, that I refer all the patients to them, and most of them are not radiated because of gross total resection, and there are very few recurrences. But we want to get to a situation where obviously we can treat meningiomas by targeted therapy or a pill. So it looks like it's going to be much more complex. Not to say anything, because you're at the beginning, you, Dr. Patel, and all of your colleagues, and Manny, of course, everybody is at the beginning of this. So I think as the years go by, we'll get to maybe more than one. Could be a mishmash of cocktail of drugs that we'll need to treat them with, So, but it's truly great summary, outstanding work, and it's really applauded.